Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today, I'm going to be doing a lecture. So normally what I do is I do content from the Blue Book, which you can see right there behind me, and I use questions to teach the content in the Blue Book because my assumption is that you've gotten the Blue Book and you have the content, but there's no questions there. So I just do the questions to go along with that. So today I'm actually going to be doing a lecture where I'm going to teach you about rheumatoid arthritis, and then we're going to do NCLEX style questions. So the purpose of today is to teach you the content in case you have a class maybe where you get this content and you just want to learn it a little bit better, and also to prepare you to take questions over the content of rheumatoid arthritis. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today, I'm going to be talking about rheumatoid arthritis. Rheumatoid arthritis is an autoimmune disorder. What that means is that the immune system is attacking our own body, or the client's immune system is attacking their own body. So normally the immune system identifies self and non-self. And so it says, well, this is me, I'm not going to attack it, or this is not me, I am going to attack it. With autoimmune disorders, the body misidentifies certain things as non-self and it starts to attack it. So the primary treatment for those types of disorders is to give something to inhibit the immune system, which has side effects like increasing your risk for infection and so forth. So we're going to talk about rheumatoid arthritis, but I think that you can take some of what you're learning today and you can generalize it to the treatment of other autoimmune disorders. The drugs that we're going to talk about today are not specific to RA. They're actually the pretty typical medications that are used to treat any autoimmune disorder. So let's go ahead and get started. You know, this YouTube channel is a part of the Greater Clinic Review organization, and we offer NCLEX reviews. It's an online, on-demand review. It's good for you. I think you can purchase however many months you want. And Mark Klimek himself teaches it. It's a phenomenal review, y'all. There's nothing better. Mark has a true gift for seeing patterns, and that's how he teaches for NCLEX. He shows you the patterns so that all of a sudden you're like, oh, I don't have to memorize this. I can just see the pattern and now I understand it. And it's really phenomenal. I think you'll really find it worth the price if you decide to purchase that. We also do small group tutoring. It's a monthly package. And then we have on-demand videos. Okay, so let's go ahead and get started. Again, I'm going to start out with the lecture portion. So rheumatoid arthritis is chronic. It's not acute. You can have acute exacerbations. So if they give you a question where it says acute rheumatoid arthritis, it doesn't mean rheumatoid arthritis is acute. It means they're having an acute inflammation. So anyone with a chronic disease can have kind of worsening and bettering of the symptoms, and that's typical also with rheumatoid arthritis. So they can have an acute inflammation, but it is a chronic disorder, and it does get progressively worse over time. It is systemic, interestingly enough. We're going to talk a little bit about the different body systems that it affects. And it's inflammatory and it is autoimmune. So it's your own immune system attacking certain things in the body, particularly the joints. It particularly attacks the synovium. So I just or the synovial fluid, the synovial membrane. So I just put that here so you can see a picture of that. You can see the synovial membrane and then the synovial fluid. And so it attacks that synovial membrane and it causes inflammation, and it can cause increased synovial fluid in there. And if they actually can aspirate the fluid out of that joint, they can actually see in that fluid the infectious agents in there, inflammatory agents in there. It's not an infection, it's an inflammation. And so they can diagnose it by aspirating that fluid out of there. The synovium actually thickens and becomes hyperemic. The word hyperemic means increased blood flow, interestingly enough. So increased blood flow is something that the body does naturally to try to get the immune system there to try to defeat whatever the problem is. And so it increases blood flow by it and allows more immune factors to get there, and that actually worsens the problem. And a fluid accumulates in the joint space. Later, that's early. Okay, so later you have fibrous adhesions. The bones can actually start to fuse together. You'll have calcifications and actually secondary osteoporosis. So rheumatoid arthritis can lead to osteoporosis and even some osteoarthritis. You can start to have some degeneration in the joint as a result of this. So it kind of all goes together, and it can be quite painful and debilitating. It is a systemic disease. So we don't just see inflammation in the joints. We see it anywhere there's connective tissue. So it attacks connective tissue, right? And as a result of the immune system itself attacking the connective tissue, the person can experience fatigue. That's an early symptom. Anemia is associated with any chronic disorder. If you get a question and it says, what are some signs and symptoms of this chronic disorder? Anemia is a good guess for just about any chronic disorder, but it does result in some anemia. Weight loss. Early on, you can see some slight weight loss. Later on, it becomes more severe weight loss. Neuropathy, so you start to have some numbness and tingling in your extremities. Vasculitis, you see inflammation of the connective tissue in the vessels. Pericarditis, you see some inflammation of the connective tissue in the heart. And then kidney disease. So these are some kind of long-term concerns that you have to watch for. I'm not saying everybody's going to get that, but they're probably going to be doing at least yearly metabolic panels to look at BUN and creatinine. They may be doing echocardiograms to keep an eye on the heart and so forth. So those are some things that they're going to be watching for. If someone's diagnosed with rheumatoid arthritis, they're going to start probably doing some annual exams, and the annual exam may be more than what an annual exam is for somebody without a chronic disorder. So someone without a chronic disorder may go in for their annual exam and just listen to their heart and their lungs and check for their pulses and make sure they're alert and oriented and draw some labs. For a person with rheumatoid arthritis, they may do some additional assessment to make sure that they don't have any of these comorbidities going along with this chronic autoimmune disorder. Risk factors, unfortunately for me, it's female between the ages of 25 and 50. They think it could be associated with the Epstein-Barr virus, and it could be associated with physical and emotional stress. That could be like the trigger that initiates it. So they're not for sure. All they can really do is look at, there's nobody's figured out exactly why it happens, right? So all they can do is look at correlation. So correlations are saying these two things kind of occur together. That doesn't mean one causes the other one. Okay, so they can't say cause and effect. A correlation is just saying these two things occur together. So being female and having rheumatoid arthritis are more likely to occur together. Being between the ages of 25 and 50 and being diagnosed with rheumatoid arthritis are more likely to occur together, right? Someone who's had a history of Epstein-Barr, you see that more often occur together with rheumatoid arthritis, but they're not saying that it causes that. They're just saying those are risk factors. It has a slow onset. They may have some of the symptoms, and they're just very vague symptoms like fatigue. They may lose a couple pounds. They may not have a great appetite. They may have some early morning stiffness. And so they kind of just think, maybe I'm just getting older or whatever. And they don't really associate it with a chronic disorder. And so sometimes it can take a while before it gets diagnosed. Later on, after it's progressed and gotten worse, they start to see inflamed, painful joints and joint deformity. So boutonniere and swan neck, this is, let me go over here and change this. So this is where you start to see the joints start to do this weird movement like this. Okay, so swan neck, where they and then they can actually see this joint like bends backwards the opposite way that you don't expect it to do that. And so it's weird joint formation. Okay, that's what you start to see. Boutonniere and swan neck, that's rheumatoid arthritis. And then you can see some secondary osteoporosis, subcutaneous nodules on the ulnar surface of the arm. And I read about why this can happen. It has to do with some breakdown of various things. And honestly, I don't remember why all that happens, but they can get subcutaneous nodules. Subcutaneous nodules is a symptom of later stage rheumatoid arthritis. And then vasculitis, that's inflammation of the vessels. And that can cause hypertension, that can cause impaired circulation to the extremities, to the kidneys, to the heart, right? So it can cause some problems that seem to maybe not be related to rheumatoid arthritis. They may be like, I'm having kidney failure, acute kidney failure, and I don't know why, right? And maybe it's vasculitis and inflammation in the vessels going to the kidneys or whatever. So those are later. These are things to watch for. Another comorbidity that you see associated with rheumatoid arthritis is what's called Sjogren's syndrome. It's where they have very dry eyes, dry mouth, and you can see some other things there. So dry eyes and I want you to know this word, xerostomia, for dry mouth. The reason I want you to know the word xerostomia is it's a symptom associated with psychotropic drugs, like any antidepressant or antipsychotic. You're going to see dry mouth. It's an anticholinergic symptom. And so dry mouth is one of the most common symptoms of any psych drug. And they may not use the word dry mouth. They may use the word xerostomia. So I want you to for sure know that word. What are some of the primary problems associated with rheumatoid arthritis? And that's something we as nurses need to think about, because remember, we manage the patient's response to illness. So they have the pathology, the pathophysiologic response, and the doctor's responsibility is to treat that either medically or surgically. And then we teach them how to manage the symptoms of the disease. And so we need to teach them how to manage the pain, how to manage the impaired mobility, how to and talk with them about the altered body image, talk with them about it, get them to talk about it, right? So you think therapeutic communication. And then impaired mobility, we're going to encourage them to have periods of rest so they can rest the joints that are affected. And then also pain management. It may be through medication, it may be through rest, it may be through warm showers or warm baths that really do help with the joints. So one of the differences between rheumatoid arthritis and osteoarthritis is rheumatoid arthritis tends to be stiff and painful first thing in the morning, and it gets better with some activity. Osteoarthritis tends to be worse after activity. So a person with osteoarthritis may feel better in the morning, and then they get more painful as they go throughout the day, whereas a person with rheumatoid arthritis may feel worse in the morning. They get up, take a warm shower, they start to do a little movement with their joints, and they actually feel better as they do more throughout the course of the day. So even though there are periods of rest are important for someone with rheumatoid arthritis, exercise is also important for someone with rheumatoid arthritis. It's kind of a sort of a difficult disease to treat. You want to do kind of a combination of exercise and then adequate rest periods as well. You don't want to rest all the time because you do need to do some exercise, but there do need to be some periods of rest. All right, how is it diagnosed? How is rheumatoid arthritis diagnosed? There's not a real clear definitive diagnosis for that other than doing an arthrocentesis where you actually remove the fluid from the joint, and you can look for the rheumatoid factor and some of the immunoglobulins that would be in that synovial fluid. But recently they have found a blood test that is pretty sensitive and specific. So when I say a test is sensitive, it means that it picks up the problem really well. Almost every time it picks up whatever it's measuring for, whether it's measuring for inflammation, whether it's measuring for a rheumatoid factor, whether it's measuring for a red blood cell, whatever it is, whatever it's measuring for, it picks it up almost every time. Specific means it can specifically diagnose a disease. There aren't that many blood tests that can specifically diagnose rheumatoid arthritis. Rheumatoid factor is sensitive. It almost always, when it's measuring for rheumatoid factor, it almost always picks it up, but it's not specific to rheumatoid arthritis. So sometimes someone can have an elevated rheumatoid factor and they don't have rheumatoid arthritis. It's very confusing. I don't know why that is, but that's the case. ANA, very sensitive in picking up inflammation, but there's lots of things that can cause inflammation. So we do measure ANA and we measure ESR, erythrocyte sedimentation. Right? They're very good at picking up inflammation. For someone with rheumatoid arthritis, they're likely to be elevated. But that alone doesn't say they have rheumatoid arthritis because there's too many other things that can cause inflammation. Really, any kind of inflammation in the body can elevate those. And then C-reactive protein, very sensitive to inflammation and infection. Someone has an inflammation or infection in their body, we're going to measure a CRP. It's one of the things we can also measure when we're worried about sepsis, right? So we can measure C-reactive protein, but it's not specific to anything. So all it tells you is in general, there's inflammation and or infection going on in the body. It's this anti-cyclic citrullonated peptide that is very sensitive and specific to rheumatoid arthritis. And so it's the anti-CCP. That's the one that is very sensitive and specific to rheumatoid arthritis. Whether you'll be tested on it or not, I don't really know. The kind of gold standard for testing for rheumatoid arthritis is really arthrocentesis, where they go in and they aspirate the fluid out of the joint. They use a local anesthetic, so it shouldn't be too painful. They may feel some pressure, but it shouldn't be too painful. They'll feel the initial needle going in where they do the anesthetic because it's just a local anesthetic. So they will feel that needle going in for that. But once they get it anesthetized, then it's just going to feel pressure. And they do analyze the fluid for inflammatory cells and immune complexes. There is some risk for bleeding afterwards, so they have to keep the joint immobile. And when I say immobile, I mean you're not going to get up and start walking on it for several hours afterwards. If they're concerned about bleeding or inflammation they can wrap it, say with a compression stocking or something like that, maybe an ACE wrap for a little while afterwards, but it's not a high risk procedure. I hope that you have a better understanding. The key thing that I want you to remember about rheumatoid arthritis is it's an autoimmune disorder. So it's their own immune system attacking their own connective tissue, particularly in the joints. It starts slowly, fairly vague symptoms, including anorexia, some weight loss, stiffness in the joints. Stiffness in the joints tends to occur early in the day after they wake up. They get up, they move around, they take a warm shower. That tends to get better. They can take anti-inflammatory medications like nonsteroidals or acetaminophen. They can also take medications that suppress the immune system. So that's another option for them. And then as it gets worse, they're going to see more swelling and inflamed joints that are going to be quite painful. They may see more nodules. They may see more severe weight loss, more severe anorexia. And then they can start to see some of the systemic problems like vasculitis. And so those are some of the things that I want you to remember, as well as the diagnosis. They can do rheumatoid factor, ANA, ESR, CRP, and then this anti-CC, I'm going to forget the name of it, this anti-CCP. Peptide. It's a peptide. Sharon, remember it's a peptide. Anti-CCP that's more sensitive and specific for rheumatoid arthritis. And then there's the arthrocentesis, where they can actually remove the fluid from the synovial joint. It's a definitive diagnosis, and it can cause a little bit of relief, perhaps, although it's going to come back eventually. All right. So which assessment findings will the nurse expect for the client with early stage rheumatoid arthritis? So early stage. So remember, we talked about it's pretty vague and slow onset. So let's see what we've got. Joint inflammation. Joint inflammation, actually, even if you can't see it externally, that is what rheumatoid arthritis is, right? It's the disease is attacking the synovial membrane and it's causing inflammation. So whether or not they can see it externally or not, that's actually what is going on. Okay, so you will see, whether you can see it physically or not, there is joint inflammation, which is what's causing the stiffness and pain. Subcutaneous nodules, that's later on. Severe weight loss. So I don't like the word severe. I know weight loss can occur, but I don't like the word severe. So I'm going to not pick it as an early sign. I would pick it as a late sign, but not an early sign. Fatigue. Yes, that is an early vague sign. Someone's like, man, I'm just more fatigued than usual. You're like, well, that doesn't tell me anything. So that's a vague symptom, often associated with chronic disorders. So I like that one as a possibility. Thrombocytosis. No reason to think that that would be an early symptom. Anorexia. Yes, anorexia is a loss of appetite. That's the reason that they lose some weight. Their appetite is not what it used to be. And I don't know why it causes anorexia other than it is the immune system is stimulated, right? So think about when your immune system is stimulated, whether you get the flu, whether you get a virus, whether you get a cold. When your immune system is stimulated, a lot of times you just don't feel hungry and you feel fatigued. You could also, if we had a low grade fever on here, I would have also picked that, because it's this immune system that's stimulated. And as a result, you kind of have these vague symptoms of just not feeling very well. And so that's probably one of the reasons why anorexia and weight loss are early symptoms. So what do we want to do as nurses? We want to control, or as multidisciplinary team members. So not just as nurses, but as multidisciplinary team members, we want to control, manage pain. We want to protect the joints. In other words, we want to protect them from getting harmed or getting worse. We want to manage mobility. We want them to be as mobile as they can be for as long as possible. And if they're having self-esteem or positive or perception problems about themselves, maybe that's changing how they look or how they feel about themselves, we want to talk about that. So let's talk about the treatment. The three probably most common ones are classified as DMARDs. I don't have that written down here, but DMARD, disease modifying anti-rheumatic drugs, DMARDs. And they're, even though they're called anti-rheumatic or anti-rheumatic, they are used as to treat other autoimmune disorders. So methotrexate, hydrochloroquine, and sulfasalazine are DMARDs, and these are used to treat other types of autoimmune disorders as well. And the key thing is they are immunosuppressive drugs. So if you start someone on methotrexate, hydroxychloroquine, or sulfasalazine, there's a couple things you need to make sure that they tell you. That you need to say, watch for any signs and symptoms of infection. If you have an infection, you need to tell your doctor, because that we're suppressing your immune system. You don't want to go out and hang out with people who are sick, right? So if people are really sick, you may want to not hang out with them. You may want to avoid large crowds. You may want to, you can wear a mask if you want to, if you can't avoid a large crowd. So, and then don't get pregnant while you're on these drugs. Okay. So these are things that in general you can teach about. And these Trexate drugs, you can get any drug that ends in ZATE. And you're going to go, well, that's a immunosuppressant. So whether it's methotrexate or another one that ends in Trexate, you're going to go, that's immunosuppressant. And you're going to teach them the same thing. Probably going to have to get your white blood cell count measured regularly, maybe not, every month, but probably every 6 months, you're going to have to get that measured. And I know for methotrexate, it's just a once a week medication. Hydroxychloroquine is every day. Sulfasalazine, I don't know for sure if it's once a week or how often it is. That one I'm not for sure. And then there's another class of drugs that it's more aggressive. They're called biologics. This would be more for someone who's having really severe pain and they're really struggling with the symptoms of the disease and struggling to kind of maintain their quality of life. These are biologics. What they do is they really interfere with the immune system. In this case, they neutralize the biologic activity of the tumor necrosing factor. Now, the tumor necrosing factor is that factor in our body that detects something that's not us. Anything that's not us, the body sort of calls a tumor. Virus or whatever, but we don't have a virus here, right? So it kind of identifies anything that's not me as a tumor. So it goes, hey, that synovial membrane isn't me. It's a tumor. I'm going to attack it. And it's our tumor necrosing factor is one of the things that attacks that tumor. And I don't know if you know this, but our immune system is our best defense against all cancers. So anything that's growing abnormally that the body doesn't recognize, it attacks. And so we would all be dying regularly from cancer if we didn't have a good immune system, which is why people with AIDS, HIV AIDS, and the more progressive AIDS end stage, they die from cancers that nobody else gets because their immune system isn't attacking it. And so the tumor necrosing factor, if you block that, that's a significant impact on your immune system. And you have to really watch for infection. So etanercept, infliximab. So I would say these biologics, if it ends with sept, CEPT, or MAB, MAB, these would be drugs that are considered biologics. If you see a drug with this name given for any autoimmune disorder, whether it's rheumatoid arthritis or ulcerative colitis or any other autoimmune disorder, you're going to see a lot of these same drugs given. And so the key thing is to watch for infection. Talk to your doctor before you take anything else. Don't just be taking over-the-counter stuff. Get permission to do that. Don't get pregnant while you're on these medications. These are some big ones, okay? And then some over-the-counter stuff that they can take with permission. Steroids isn't over-the-counter, sorry. Steroids would be short-term. Generally speaking, they don't put people on steroids long-term. We're talking about like prednisone, because there are long-term side effects of these things. You have to watch for hyperglycemia with steroids. You have to watch for osteoporosis with steroids. You have to watch for increased risk of infection with steroids. And you've already got risks of infection with these other medications. You've got risk for osteoporosis with rheumatoid arthritis in general. So steroids are used more for an acute inflammation that's associated with the chronic disease. So if someone comes in with, I'm just misery, I'm all inflamed, I'm horrible pain, they can come in and they can be treated with steroids short term. Acetaminophen is more of a daily kind of a thing that they can take, but make sure they don't take more than 4,000 milligrams a day, which is 4 grams a day. So extra strength Tylenol is 500 milligrams, y'all. So if they're taking extra strength Tylenol, 2 is 1,000 milligrams. So they can't take more than 8 maximum. And I would go so far as to say, I would go with 6 to be safe, because you don't want to cause liver damage on top of everything else. So I would go with 3,000 milligrams a day, but 4,000 milligrams is the maximum they're allowed to take. And then non-steroidal anti-inflammatories like ibuprofen, naproxen sodium, these are non-steroidals. And then there's the COX-2 inhibitors, which are the non-steroidals that don't have the same GI upset that non-steroidals do. But there's some other issues with COX-2 inhibitors. I'm not sure how much they're prescribing these anymore, but I know they still use a lot of Tylenol and Advil and naproxen. These are all the trade names of the non-steroidals you can buy over the counter. All right, let's do some questions. A client is diagnosed with rheumatoid arthritis. It started on methotrexate. So remember, methotrexate is a disease-modifying anti-rheumatic drugs, and they suppress the immune system. So methotrexate, which statement made by the client indicates to the nurse that further teaching is needed regarding drug therapy. So further teaching, we're looking for the false statement. Methotrexate, we reviewed what that was. Drinking alcoholic beverages should be avoided. True. That's true. The healthcare provider should be notified 3 months before planned pregnancy. True, because they're going to take them off the medication. Any side effects of this drug will be mild. No reason to think that. You're suppressing the immune system. You could have some significant side effects. So C seems like a false statement to me. I will avoid any live vaccines. Well, that's a true statement. You're taking something that's suppressing the immune system. You take a live vaccine, you're going to get sick with whatever you just injected into yourself. So the only one that's a false statement is that any side effects of this drug will be mild. Before administering prednisone IV push to a middle-aged adult with rheumatoid arthritis, the nurse notes that the client's random blood glucose level is 139, which action is most important for the nurse to take. So prednisone is a anti-inflammatory. It's a steroid, anti-inflammatory drug, so I know why they're getting it. But their glucose is already a little bit high, but it is a random blood glucose. So it's not a fasting blood glucose. It's a random blood glucose. So this person needs to have prednisone for their rheumatoid arthritis. Maybe it's an acute exacerbation. I don't know. But anyway, they're getting this drug and they're saying their blood sugar is already higher than normal. So does that contraindicate the use of prednisone? That's the question. Let's see what the options are. Instruct the client to drink diet soda to prevent elevation of blood sugar. I don't usually recommend diet soda to people. That doesn't seem like a good NCLEX answer. Now, I'm not saying in real life I wouldn't say that, okay? But on the NCLEX, that doesn't seem like a good answer to me. Administer the prescribed prednisone on schedule. Well, I mean, they're supposed to get it, so that seems fine. Notify the healthcare provider of the random blood glucose result. Okay, maybe. Review the client's anti-nuclear antibody level. No, because I would expect their ANA to be elevated if they have rheumatoid arthritis. So I don't like A or D. So would I administer it or would I notify the healthcare provider? So I'm going to go back and reread the question to clarify what I might want to do here. Before administering prednisone to a middle-aged adult with rheumatoid arthritis, the nurse notes the client's random blood glucose is 139. Which action is most important for the nurse to take? It doesn't say first, it says most important. This is a prioritization question. So what's your priority? So if you can only do one thing, is it more important to follow the doctor's order and give the medication to a client who needs it, and I know they need it because they have rheumatoid arthritis, or to notify the healthcare provider and about a blood sugar 139, which generally speaking, we don't do anything about, just in general. If it's under 140 in general, we don't do a lot about it. So I can only do one thing. So I'm going to administer it, but not notify the healthcare provider, or I'm going to notify the healthcare provider and not administer it. Y'all, there's no reason to notify the healthcare provider. I may notify the healthcare provider later if it goes up over, say, 150, but I'm not going to notify them about 139. Do you know what they're going to tell me? They're going to say, yeah, give it. I ordered it for a reason. Look, if the prednisone causes the blood sugar to go up, we'll treat it. But I'm not going to not give the prednisone because he's already borderline high right now. The nurse assesses the client diagnosed with Sjogren's syndrome. The nurse anticipates that the client will also have which common condition? All right, so I put this question in here to test your memory about Sjogren's syndrome and also to test your knowledge of vocabulary. Increased lacrimation. What is lacrimation, y'all? Lacrimation is tear production. Okay, so increased lacrimation, increased tears, abdominal bloating after eating, diarrhea, or xerostomia. Well, what's xerostomia? Xerostomia is dry mouth. What's Sjogren's syndrome? It's dry eyes, dry mouth, and other places can be dry. So I don't want to pick, well, B and D are off the list. I don't want to have increased tears. I want to have dry eyes, not increased tears. So I'm going to pick xerostomia, which means dry mouth. The nurse is reviewing the medication history for a client diagnosed with rheumatoid arthritis who has been ordered to start sulfasalazine therapy. The nurse plans to contact the healthcare provider if the client has which condition: sulfa allergy, glaucoma, hypertension, or hypothyroidism. So I put this question in here to test your common sense. When you don't know the answer, how do you guess well? Let's use common sense. Sulfasalazine, and we might go, I don't know why I would contact the healthcare provider. I'd contact them if they have a contraindication to taking this medication, right? So is sulfa allergy a contraindication? Well, it's sulfasalazine. So use your common sense. That seems like if they have a sulfa allergy, sulfasalazine might be contraindicated. Glaucoma. Well, sulfasalazine impacts the immune system. Glaucoma is not an immune disease. It's not an autoimmune disease or an immune disease of any kind. Hypertension is not an immune disease. Hypothyroidism is not an immune disease. So there's no reason to think B, C, or D, which have nothing to do with the immune system, would be impacted by giving an immune suppressant, whereas a sulfasalazine might be contraindicated if the person has a sulfa allergy. Y'all don't memorize this. There's no reason to memorize this. This is common sense. And when you get a question like this on your NCLEX, they're testing your common sense. They don't necessarily think that you memorize this information. They want to know if you go, oh, that would make sense that you can't take a sulfasalazine when you got a sulfa allergy. Which instructions for joint protection does the nurse recommend for a client with a connective tissue disease? So it's a connective tissue disease, right? There are other connective tissue diseases. Rheumatoid arthritis is one of them. And so what do we want to do for joint protected joints? Remember, I told you one of our goals is joint protection. So use long-handled devices such as a reacher. So a long-handled device such as a reacher. So a reacher allows you to reach farther. So if I have connective tissue problems, maybe I have trouble grasping things, maybe I have trouble lifting my arm up very high, I can use something to reach it and grasp it, right? So that's what a reacher is. A reacher is something that has a handle that you just pull back on, and it reaches and grabs at things for you. So that seems like something they could use with a connective tissue disorder. When getting out of bed, use your fingers to push off. No, you should use your hands. Use your full hand to push off, because if you're just using your fingers, you're putting a lot of stress on those joints. Sit in a low back chair. Why? Why would I sit in a low back chair? That doesn't give me any back support. That doesn't seem like a good idea. Bend at the waist. I never tell people to bend at the waist, y'all. Never, never, never tell people to bend at the waist. I always tell people to bend at the knees and the hips. Use adaptive devices such as Velcro closures. So Velcro closures prevent me, can't really see this. If I have to do a button, I have to use my fingers and joints. Well, if I use a Velcro, I just have to pull it. I don't have to button little buttons. So that would seem reasonable to me to use Velcro closures. Turn a doorknob clockwise. Y'all, that makes no sense. You already turned doorknobs clockwise. That does nothing to protect the joint. That doesn't make any sense. All right. So in this case, A and E are two ways to protect the joints. There's other things they could say to protect the joints. You can get utensils that have a bigger handle on them so that you can grasp them instead of having to do this. You can grasp them like this. To protect the wrists, you can get wrist guards, things that like wrap around them or whatever. So there's various things. So just use your common sense. If you get a question about joint protection, just use your common sense and go, does this make sense that this would protect the joints? You can't really memorize a list of all the different ways you can protect the joints. A nurse teaches a client about heat and cold treatment to manage arthritic pain. Which statement indicates that the client still has a knowledge deficit? Okay, heat and cold to manage arthritis pain. Well, can we use heat and cold to manage rheumatoid arthritis pain? I didn't tell you about that. Well, yes, I told you like taking a warm shower in the morning can really help, and it can. And if you have a lot of inflammation, so cold is used to treat inflammation. So if they have a lot of inflammation, they can use ice or cold. And then if they're just really sore and stiff, they can use heat. So they can use both heat and cold to manage it. So what indicates they have a knowledge deficit, which means they need further teaching. So further teaching is a false statement. So I'm looking for the false statement, false statement, false statement. I can use heat and cold as often as I want. I don't think there's any limit on how often you can use heat and cold. That seems fine, like a true statement. If nothing else makes sense, I can come back to it, but that seems okay. With heat, I should apply it for no longer than 20 minutes at a time. Well, I know that there are time limits for both heat and cold, so 20 minutes seems reasonable. Heat-producing liniments can be used with other heat devices. Okay, that seems dangerous to me. So heat liniments are things like icy hot or whatever, like creams that you can buy at the grocery store, and you put them on and they actually produce heat. If you use that and a heating pad, that means a liniment with other heat device. That's like using icy hot plus a heating pad. That can actually burn the skin, y'all. That is dangerous. So C is false. 10 to 15 minutes per application is the maximum time for cold applications. That's a true statement. 10 to 15 minutes is the maximum time for colds. So the only false statement here is C. The teaching plan for the client with rheumatoid arthritis includes rest promotion. All right, I told you that, so fine, we're okay with that. What position of the involved joint should the nurse tell the client to avoid when it rests? So all of these things are fine except one of them. So I'm going to say, okay, not okay. All right. So I'm looking for the not okay. Keep all joints aligned. Well, I always keep all joints aligned. Y'all, that's a universal principle. Keep all joints aligned. What am I going to do? Unalign the joints? No, that's okay. A is okay. Elevate the affected joints. I don't see why not. It's an inflammatory disease. So if I keep them elevated, that seems okay. Lie in a prone position. Prone is flat on your stomach. Supine, I don't know why not. I mean, you can lie in a prone position, I guess. I mean, it definitely keeps your joints straight if that's what you want them to be. Maintain the joints in a flexed position. Okay, that I know is not true. And I'll tell you why I know that's not true. I know that's not true because I have arthritis in my fingers. And if I keep my fingers flexed while I'm sleeping, I wake up with them flexed and hard to unflex. Okay. So that I know from personal experience is not true. So I'm just sharing that with you, whether that helps you or not. Remembering Dr. Sharon can't keep her fingers flexed at night while she's sleeping. If that helps you remember it, perfect. But we don't keep the joints flexed. It's true whether it's the knees or the elbows or the wrists. Don't keep them flexed, right? So if you sleep like this, right, that's probably not your best option. If you have rheumatoid arthritis in your wrists or your hands, that's probably not your best option. And yeah, I know that because I always used to sleep like this. That's how I always slept, and I can't sleep like that anymore. Which of the following instructions should the nurse provide to a client following an arthrocentesis? So what's an arthrocentesis? Where they go in and they pull fluid out of the joint, okay? And we talked about that. You remember what that is, right? It's not a big deal. They numb the area and you watch for bleeding afterwards and maybe some swelling. So those are some things to think about. Which of the following instructions should the nurse provide? Okay. Apply heat to the joint for the first 24 hours. Heat to the joint? That doesn't seem reasonable to me. I've never applied heat to something after a procedure because usually you want to decrease inflammation. So if anything, I would apply ice if it was, or cold if it was inflamed. That doesn't make sense. Apply heat. Limit movement of the joint and apply an elastic bandage if advised. All right, so you're sticking a needle into the joint. Does it seem reasonable that you would limit the movement of the joint following the arthrocentesis and applied elastic bandage if advised? Y'all, that's a good NCLEX answer because if it's advised, you're going to do it. Now, you're not going to limit movement of the joint like for years or anything like that, but maybe for a few hours. That seems reasonable. So B seems reasonable. You should expect mild bleeding at the site for several days. No, absolutely not. You should not expect mild bleeding at the site for several days. You might get a spot of blood on the bandage afterwards, but that's all you should expect. Start physical therapy the day after the procedure. Well, no, I mean, no, that doesn't seem reasonable. Why? I don't, that's not computing with me. No. So the only one that seems reasonable to me is B. And, if I pick D, I would have to really overthink this question to pick D. So if you were tempted to pick D, y'all, you're an overthinker because you would have been like, well, maybe they need physical therapy. Y'all, they don't need physical therapy. That's not what they need. No. 25-year-old client taking hydroxychloroquine for rheumatoid arthritis calls the clinic to report difficulty seeing out of the left eye, which is the nurse's best response. So we know hydroxychloroquine is actually an anti-malarial drug, but it suppresses the immune system. All right, cataract development. All right, Kate, let me reread this. Calls the clinic to report difficulty seeing out of the left eye. So y'all, I don't know what the side effects exactly of hydroxychloroquine are, except that it suppresses the immune system. But I certainly don't expect him to start having difficulty seeing out of the left eye. That doesn't make any sense to me. Cataract development is a side effect of hydroxychloroquine. It seems like That's a pretty big deal. That doesn't seem like a side effect. That seems more like a complication. Come to the clinic to let us look at you. That seems like a good idea. This is part of the disease process. There's nowhere that I've read that vision changes as a part of rheumatoid arthritis. This should resolve on its own. Not that I know of, y'all. Someone has a symptom that you go, that's unexpected. Say, come on in and let us see you. Come on in and let us see you is a good NCLEX answer. And I put this in here intentionally to teach you that. So especially they like to do this with diseases that you don't know much about or drugs that you don't know much about. They'll ask you a question. They'll give you something the patient's experiencing related to this disease or this drug. And you're like, well, I've never heard of that before. Y'all, if the option to have them come in and let them be assessed is there, pick it. It's a safety issue. They're trying to say, do you have enough common sense to tell this patient, hey, this is not expected. Come on in and let us see you. Okay, that's just common sense to do that. A client with rheumatoid arthritis is taking high doses of nonsteroidal anti-inflammatory medications. What should the nurse teach the client about taking these medications? All right, nonsteroidals, not steroids. Nonsteroidals like ibuprofen. So I'm just going to use the word ibuprofen to keep my brain where it needs to be. Okay. For someone who is taking ibuprofen for their rheumatoid arthritis, I would say take the prescribed medication with food to lessen the likelihood of an upset stomach. Absolutely. With ibuprofen or any of the other nonsteroidals, I say take it with food. That absolutely, they need to do that. Someone taking ibuprofen, I say do not stop taking the medication suddenly. The dose needs to be decreased gradually. Ibuprofen does not need to be decreased gradually. Steroids do. Prednisone does, but not ibuprofen. For someone taking ibuprofen, I say use mouthwash to rinse the mouth after taking this medication. No, I've never told anybody that taking ibuprofen. No. For someone using ibuprofen, I say do not drive or use heavy machinery if dizziness occurs. Well, it's true that I would say if dizziness occurs, you shouldn't drive or use heavy machinery, but that's not specific to ibuprofen, whereas A is specific to ibuprofen. So I'm going to pick the answer that's specific to the question that's being asked. Even if I say, well, D, this seems like common sense. Yeah, but it's not specific to the question that's being asked, whereas A is specific to the question being asked. A client with rheumatoid arthritis tells the nurse, I know it's important to exercise my joints so that I won't lose mobility. That's true. But exercise is difficult with my stiff and painful joints. That's also true, which is the best nursing response. So they're like, this is tough. I know I need to do it. And then what does the nurse say? Tell the healthcare provider about your symptoms so they can increase your pain medication. Maybe stiffness and pain are part of the disease. That's true, but it's not very therapeutic. And the reason I don't love A is because it's deferring it to someone else. Now, if none of the other answers make any sense, I guess I can defer it to someone else. But in general, on the NCLEX, they like us to deal with it and not defer it to someone else. So A is deferring it to someone else. B is not very therapeutic. C, take a warm bath or shower before exercising. Well, that's me addressing the problem, giving them good advice, teaching them. That's good. You're probably exercising too much. Well, they haven't told me how much they're exercising. They say they can't exercise because of it. So no, that doesn't make any sense. So if I don't want to defer to someone else, or I don't want to be kind of, like forget about it, that's just part of the disease, like blowing off their concern, then I have to pick C. A nurse is providing pre-procedure teaching to a client scheduled for arthrocentesis, pre-procedure teaching. Which of the following statements by the client indicates a need for further teaching? So they're going to have that procedure where you stick the needle in the joint, aspirate the fluid out. What requires further teaching? So I'm looking for the false statement. I should avoid taking any blood thinning medications before the procedure. Well, that's a true statement. And I'm looking for a false statement. The procedure will help drain excess fluid from my joint. That's true. I will need to avoid moving the joint for at least 48 hours after the procedure. I don't like that. It says at least 48 hours. That's making it seem like I'm going to tell them to keep that joint immobile for 2 days or more. That doesn't seem like a good idea, especially if they have rheumatoid arthritis. I mean, it doesn't say they have rheumatoid arthritis, but if they're having an arthrocentesis, like, you got to move the joint. That doesn't seem like a good idea. I may feel some pressure, but the area will be numb. That's a true statement. So I know A, B, and D are true statements. So C, I felt a little bit uncomfortable with, and it kind of solidified the fact that all the others were true statements. So I'm going with C as the false statement. After undergoing arthrocentesis, a client reports increased pain and swelling in the joint. That's unexpected. They should have decreased pain and swelling in the joint after arthrocentesis. They just removed a bunch of fluid. What is the nurse's best response? So they just said, hey, I'm having increased pain and swelling. What do I say? I say it's unexpected. So I have to do something, which means because we do something about unexpected findings. This is a normal response. Apply ice. No, that's unexpected. I'm not going to tell them it's normal. You should rest the joint and increase your fluid intake. That's essentially telling them it's normal. Just tell them to rest. You may need a second procedure to remove more fluid. I don't know that. That's totally outside of my scope of practice to say that. Notify your healthcare provider immediately, as this could indicate infection. That's true. Now, in the previous one, I just said don't defer it. But when do we defer? We defer when it's outside our scope of practice. Okay. So teaching a patient about taking a warm shower is in my scope of practice. Telling them why they have increased pain and swelling after a procedure is outside my scope of practice. So I need to make sure I direct them to the person who is the appropriate person to deal with this. Okay. So you have to use, again, good common sense, good clinical reasoning to know when you defer it and when you don't. Most of the time on the NCLEX, I will say you're not going to be deferring it. There may be 1 or 2 questions where you defer it so that they know that you understand your scope of practice. But most of the time on the NCLEX, they're going to want you to address the problem through teaching, usually through teaching or whatever it is. Okay. So, and I'll tell you why they like you to do teaching is the RN scope of practice they look at as a hierarchy. At the top of that hierarchy is teaching. They consider teaching to be the most complex action that nurses, RNs do. And at the bottom is like skills, because anybody can do a skill. Like literally anybody can be taught to do a skill. You don't have to have a degree for that. So they consider teaching to be at the most complex action that we do. So that's why you get so many teaching questions on the NCLEX. They want to know if you're able to teach. They want to know if you're able to practice at the top of your nursing license. Okay. So good luck on every test that you're taking. I hope this is helpful for all learning rheumatoid arthritis, learning about autoimmune disorders, and learning how to take NCLEX questions. That was my goal. So I hope that helped. All right. Have a great rest of your day.